All right. It's really nice to be here, and it's really nice to see some friends and some old faces and some very young faces. Thank you. I'm Dr. Abdullah Ozairi. I'm currently on sabbatical, but I've got a bariatric or psychobariatric fellowship from Toronto, and we did quite a lot of work in Emiri to start this process in Emiri, and we hope to kind of use that same experience elsewhere. This is kind of, I'm not going to ask you to all to be psychiatrists, but just to be aware of what the issues are and how to go on about it. And so it's really based for yourself. I'm asked, so the first part I was asking, what are the psychological side effects of bariatric surgery? Then what happens with psychiatric medications, and what happens with the new GLP-1s when we use them in context of bariatric surgery, and what to do about them as well. So I'm a strong believer in surgery. Genuinely, I think as gastric sleeves and gastric bypasses have revolutionized the healthcare system for obesity. And I think without surgeons, treatment for obesity would not be the same. The main issue is the sleeves work, and they're amazing. They're amazing for psychiatry because they reduce depression, and you see the quality of life difference. My God, their sleeves amazing. Sometimes when you treat someone with a sleeve, by a huge obese person, you treat them with an obese, their whole life changes, their functioning changes, their physical function. To see them, the way they think of themselves, the way they look, they never want to get back to that. In fact, that's part of the issue. Is sometimes we treat them too well that they develop eating disorders beyond, because they now have anorexia and they can't. Oh my God, I'm at 50 kilograms right now. I can't go to 52 kilograms. So, they're 160 centimeters. Their BMI is 17. One of the things that's actually interesting, that lower quality of life, there was a recent study about a lower quality of life about 3 months ago that said lower quality of life pre-morbid to surgery is one of the ways that is one of the associations that maybe they'll not lose as much weight. And so that was an interesting thing, because when we looked at depression and anxiety, etc., that wasn't clear. But quality of life seems to suggest that obviously after the surgery, they tried to kind of say, this is not what I really wanted. I thought this would be even a better success. And how many people have done sleeves and have not achieved their weight goals? And so that turns them to lower quality of life. Even if they've lost 15 kilograms, 20 kilograms, they wanted 60 or 70 or 100, right? And so that's one of the other things. The inadequate weight loss and weight regain, the cross addiction. And what do we mean by that? Cross addiction is when you might be addicted to food, and then now you're addicted to something else. Okay? And we know, for example, even in Kuwait, we have some data, but not published, that alcohol abuse goes up, even in people who have never used alcohol before, after sleeves. And I see that constantly in the clinic. So that was interesting. People who never used alcohol say, haram, tafallah. Start using alcohol because they want to kind of achieve that effect again. And we know with alcohol, it's interesting. There's increased rates of suicide. And so I say all of these things. These are the bad things, right? But they're a very small percentage. Now, the question comes back to the surgeons, to the nutritionists, and everyone else. Is absolutely, I think 95% of cases, beautiful recovery. No psychosocial issues. And honestly, the depression, I can refer to a psychiatrist. I can include a psychiatrist from the beginning. Okay, and we'd like that. The problem is in the 5 to 10% that are not recovering. Okay, and so this is the problem we're going to talk about today, and I'll show you some literature about that. And so this is why the psychosocial support is recommended by almost every guideline, because you need a psychologist, a psychiatrist to kind of be involved in that team. Okay, so in Amelia, for example, we have a child psychiatrist, an adult psychiatrist, and 2 psychologists with authority, one for counseling, one for therapy. And have to stop looking. There. So I just told you this, but I just want to show you pre-surgery and post-surgery, 2 years and 3 years, their mood gets better. Right? So this is mood, for example. Their anxiety, the blue stuff, gets better. So lots of psychiatrists are against, no, let's not disturb things. They disturb how cipralex is absorbed through the body, how Effexor is absorbed, how lithium is absorbed, the antipsychotics are. I don't know. I'm actually very pro bariatric surgery. If I could get it, and if I had just a little bit higher BMI, I'd take bariatric surgery any day. Honestly, I think it's wonderful. I think it's wonderful for mood at that. Having said that, how many people have seen relationship difficulties after bariatric surgery? My God, how many divorces or separations have there been in Kuwait? That's actually, so I spoke to one of the people, the family courts, and they said that was one of the second probably reason for divorces in Kuwait. It's after bariatric surgery, either because the husband gets jealous because she's losing a lot of weight, or they don't like the skin folds, and you hear stories about that. The plastic surgery and the scars beyond that. So it really is something that we have to be telling our patients. So this is something that's important, and including the partner. So it's not just a single person, but including the partner in these discussions, or having them talk about body image issues after it with the excessive skin folds, but also the eating disorder that often happens. So, and then new maladaptive behaviors, stop smoking, drinking, etc. has all started. So new onset mood and anxiety disorders also happen. Exacerbation of pre-existing mental illnesses can happen. New eating disorders and new substance use disorders. That doesn't surprise all of you. But the question to you is, and this is what happens with the surgeons I speak to and the surgeons I work with. They tell me, yes, but it works beautifully for 90% of patients. And I say, absolutely. But you should be caring about that when that person is in the clinic. This is the only person you should be concerned about. Okay? And so we may have to make sure who to choose, what to do, and what supports can we give them afterwards. Because at the end of the day, the job of the surgeon is to provide the best care for that patient. And we need to be involved, and that needs to be addressed. Now, I'm not telling you do therapy with that patient. My dad's a surgeon, I know. He'd run away. He'd abandon the whole family, move to another country, right? Instead of doing therapy with a patient. I know that. That's one of the things I want you to think about, is asking about these things and referring on. So alcohol, this is 2 large studies, the Swedish study and the Soberg studies. Both, this is from the Swedish study, says alcohol really increases. And why is that? It's because the alcohol response factor, you know this, alcohol is quickly absorbed after sleeve or after bypass, and it's much quicker, almost 10 times the addiction list. Okay? And so it really goes about 6 times about substance abuse or alcohol abuse in particular. Okay? And so the alcohol reaches a very quick peak, about 4 times after Roux-en-Y. So it has a much nicer effect. Okay, it's a much nicer effect. So if anyone wants to really not be an alcoholic, but to get the best high from an alcohol, do a sleep first. Okay? That's one way to increase alcohol. And in Kuwait, the alcohol prices are just too expensive. And so a bottle will take you a much higher, much cost. But on a serious note, I'm not recommending people to use alcohol or to get sleeves for that reason. Right. The odds ratio of suicide, almost 4 times the risk. 4 times the odds ratio. Can you imagine that? So there's something about the suicide that increases after bariatric surgery. And you know that from the Swedish study. And we know that when you include substance use, and we know that trauma before sleeves or before Roux-en-Y is actually something that's considered. And as psychiatrists and psychologists, we always ask about trauma. And I wonder if you should too. Just, have you ever had verbal, physical, or sexual abuse? So we ask that, just exactly that question. We don't go into what it is. We don't go into anything else. Have you ever had that? That's a significant predictor. One question. That's all it takes. Okay. One question is, have you ever had suicidal ideation before? I don't need to know what happened, why, what's wrong. That's not the surgeon's job. I found that for them to. Right? That's something to think about. So, previous psychiatric history. That's all you need to write on the referral. And then we talked about medications reacting differently. So people who are on psychiatric medications, and almost any psychiatric medications, if they're going to receive, it will almost change the absorption. There's particular ones like the extended release. So Wellbutrin, Effexor, lithium, Depakine will change significantly. And so here we divide them into what to do, and we can talk a bit about that. All right. So things like unrealistic expectations. People who are 130 and want to lose down their weight to 50. Right? I literally just saw that patient yesterday. And she was very upset because she only lost 10 kilos. From 130 to 120 is not what she was looking for. Now, I don't know if that's... and then, how many of those go into revision surgeries? Lots. And likely the revision surgeries are not going to be as effective as they want it to. And because the problem is in the expectation and not the health benefits, but the expectation of going back to 50. He talked about the substance abuse and the reduced absorption of psych drugs. And then the reduced ghrelin, which is an anxiolytic, and talked about the relationship destabilization. All these factors really play into suicide. So when you see these, when you hear about them, please think about referring. Okay. But the point is, you should be asking about the issues. Okay? And it really is just one question. How is this affecting your relationship? Is this affecting the relationship with your husband, with your spouse, with your important other? That's all. Okay. Now, eating disorders. Yesterday, I saw someone who weight of 130, BMI of 40, was height is 160. I think that's around right. I had the scores. Anyway, she came in 12 years later. Her weight was 48. She's now developed anorexia, and that was never picked up. And she, in fact, talks about having, she's skinny as anything, looks sick. But she talked about, I'm still too fat. I need to go to the gym, and I can't get. I'm so worried if I go above 52, that would be a nightmare. I can't survive. I'm having suicidal thoughts because I can't, I'm ruminating. What happened? She's 48. She goes to exercise every day. Her muscle mass is very low. Her fat is very low. Her water intake is very low. But she's so absorbed about the weight. And even at 48, she looks like a skeleton. And yet she still thinks she has the issues of weight loss and wants to continue weight loss because she's, in her mind, she's so worried that she's not going to be back to 130. And this is someone that could easily have been prevented to get anorexia or eating disorders at the 5 years, 11 years down the line. It's much harder because the anorexia has really taken a hold of her. In the beginning, she was just so happy with her actually initial line was from 130, she wanted to be 70. But that constant thought, that constant development of, I need to lose weight. I can't gain this weight. Everyone else has gained this weight. I can't continue to lose this weight. And she lies, and she lies all the time. And she's, it's a constant behavior. Okay. She was one of those people who had, we talked about abuse. That was one of the predictors that could have linked us to it. And the surgeons never asked. It was like the medical doctor then to ask him. And thinking about the weight regain, but then the unconscious sabotage. So people, how many of you ask before doing revision surgery, especially before doing revision surgery, about purging? That's another thing that we need to ask. Purging is using your hands to make yourself vomit, right? And so thinking about purging is a real important predictor, and it's actually one of the predictors of not doing well after surgery. So binging, I'm not so worried about. Binging is very important to ask about, but easily very controlled. People who binge before surgery tend to do really well at post-surgery. Okay, now we have to treat the binge eating disorder. So binge eating is when you eat a huge amount all at the same time, and it's usually to react to an emotional response. Okay, so on a Thursday night, when it's the end of the workday and you're very tired, anyone who is above the age of 30 knows what I mean, especially after the age of 40, that really hits. On Thursday night, I don't want to go out. I would just stay home and probably just relax and maybe binge because I'm just tired after a week. Okay. And so that often binges happens with sleep, lack of sleep, lack of health. But binges in general can be easily treated, I promise. Okay, so other people will say binge eating is a really big thing, and that was true 10, 15 years ago. That was where the evidence was. But since then, we've moved on to say, binge eating, refer them on very early, please ask about it. But that's all we have to do. So the psychiatrist or the psychologist takes it 2, 3, maximum 6 sessions. The binge eating disorder is gone post-sleep. Okay. Because they're losing weight. That was all their intention. They were trying to binge, and then they tried to starve themselves because they want to lose weight. Now we've given them what they want. It's a predictor, but it's not. This purging, my God, we need to make sure that we're asking about that. Okay, so binging, purging, and use of laxatives is another. Talking about surgical complications and food aversion and phobias. Food aversion is when, you know how some people post-bariatric really don't want to go back to eating a particular thing. But also sometimes people just stay on, I've seen people who have stayed on soft food for a year. They're so worried about eating solids. And it's a worry. It's not that they can't, it's not that their stomach is, it's not a surgical issue. It's just they don't want to move on to avoid gaining weight. I'm okay, I'm losing weight. I've seen 2 people like that, and it's mind-boggling. I love food. I live for food. Food is one of the best things in life, and so how do you not eat food? I'm not sure I understand that. Okay, so, but that's some things that happen. And sometimes it's particular foods. And so we need to be asking about that. So chickens, meat, etc. Talking about anxiety about eating changes, because when people do a sleeve or a bariatric surgery, their whole life changes. It's not the same. Your relationship with food changes, but also that relationship means you can't go out as much, you can't do as much, etc. And it's not that you can't, but it happens all the time. And anyone who does these things knows about that. And so how do we do that? And how do we make sure that there's a regular behavior, that we have behavioral adjustments, that they get over these things so that they can live a
Dr. Abdullah, 2 minutes.
All right. So, talked about body image, depression, self-care, social anxiety, and sabotage to avoid anxiety about food. So sometimes they sabotage themselves to avoid anxiety. They don't go out, they don't, because they don't want to say about the sleeve. They don't want to talk about what the sleeve does. There's a significant now developing evidence that it changes the way we think. Okay, so especially post-bypass, this is very true. So some people talk about an improved cognitive function. Okay. And some people you'll see, especially in Kuwait, who don't take vitamins and don't take their supplements very well. You see their attention span and their working memory, which is how much you can process in your brain at the same time. Okay, and it's usually 7 things. That's why our old phone numbers were 7, right? Because that's the amount of brain that you need to remember a number. And then mobiles came and nobody knows numbers, right? But regulates. So that's one of the things that on MRI, we see some neurological recovery sometimes in white matter and gray matter changes since the bariatric surgery. And we see some deficiencies sometimes in hippocampal if people are not, especially if people are not taking their supplements, but that can happen in other places as well. So short-term memory sometimes gets worse, but overall the cognitive function can improve. So this is something that we need to be thinking about, okay? And it's probably an inflammatory response. Okay, referring to what psychotherapy. I think that's the hardest thing. Honestly, when we started opening the bariatric clinic in Amiri, the hardest thing is the psychologists were not trained, okay? And if you use a psychologist to assess, maybe that's fine. But then what to do when you pick up something? And that's a really hard question. And we've developed quite a bit of learning and experience with those people. And generally, the psychiatrists are getting more and more involved, in all honesty, in Amiri. Because the more complicated cases, the psychologists say, I don't know what's wrong. They don't have enough of the educational background, background and information of that. And I'm not trying to dismiss psychologists. In fact, I refer to them all the time, I promise you. But post-bariatric, I think that's something to be thinking about.
So Abdullah, I think we are over.
A lack of knowledge, but thinking about CBT and ABT. All right, so I'll stop here. Actually, I'll mention one thing because this is important for everyone as a medic or a surgeon. Sorry, just one last slide. I apologize. Medications that really need to be watched for. So sodium valproate, we need to switch from XR to IR. And also lithium should be probably never continued. So it should be switched at when someone has the surgery. Okay. And so be careful of dehydration post-op. Lithium toxicity is very dangerous. It can kill someone. And then when we restart, we do weekly lithium levels. I don't care what the psychiatrist says, if it's monthly or if the patient says, I'm very stable. The metabolism of it really actually changes post-leave. Okay. All right. And then antipsychotics gain weight. I'll stop there. And I'll open the floor to questions.